So I wanted to introduce our presenters today. So we want to thank you for attending our continuous privacy and security compliance presentation today. Our speakers are James Lawson from Iatric Systems and Mac McMillan from Synergist Tech. James is the Vice President of Strategic Integration Development at Iatric Systems and has extensive expertise in McKesson integration. He has more than 14 years experience working with multiple healthcare information systems, and he can help you optimize your systems and data to maximize efficiency and usability. Mac McMillan is a co-founder and CEO of Synergist Tech, a firm specializing in the areas of information security and regulatory compliance for healthcare. He is the current chair of the HIMSS Privacy and Security Policy Task Force, and he brings over 30 years of combined intelligence, security countermeasures, and consulting experience to his position from both government and private sector positions. So at this time, I'd like to turn the floor over to Mac.
Okay, thank you very much. Welcome, everybody. And I'm very pleased to be here this morning and have James Lawson joining me to present to everybody. And we're going to talk a little bit about what's going on out there in the world with respect to privacy and security and how that's affecting us. Talk a little bit about what we're seeing with respect to the OCR audits that are ongoing right now from a compliance perspective, and some of the lessons learned from that, and some of the things that maybe hopefully you folks can take away with respect to improving your programs and being more prepared should you have an audit, but more importantly, being more prepared for handling the challenges that privacy and security present to protecting patient information and patient safety, which is really the most important thing of all. So with that, let me go to the next slide real quick. And I see pictures of James and I, so we'll go past that and get to our agenda. So like I said, we're going to talk about this evolving landscape, talk about the audits, talk about how technology hopefully assists us in addressing some of those things, and then answer your questions and have some discussion. So first, factoid. One of the things you're going to see throughout the presentation is some factoids. These are just kind of fun little vignettes, if you will, ideas that we put in here to present. And I'm going to read the question and give you guys a chance to select your answer, and then I'll go through the answers. And hopefully from these you'll actually be able to garner some useful information in terms of understanding what's going on in the environment, but also with some of them you may be able to measure yourself or your own program, if you will, against what some of the industry norms are with respect to what we're seeing from some of the surveys and interviews that are done out there. In fact, most of the questions that you'll see in these factoids come from very prominent surveys, such as the one by HIMSS Analytics or Ponemon Institute, etc. So this first one here asks the question, is healthcare data more accessible today than ever before due to digitization of records, greater connectivity, and proliferation of mobile devices, something that all of us understand. The greatest threat is it hackers, authorized users, third-party service providers, or all of the above? I'll give you a second to think about that. So the answer is actually authorized users, but what I'd really like you to consider is that it's maybe all of the above as well. And what I mean by that is when you look at the statistics that come in with respect to the breaches, every one of these is represented in the breaches that we've seen over the last couple of years that have been reported. Certainly the ones that are committed by internal users with respect to mistakes or inadvertent disclosures or losses of technology such as laptops, mobile devices, etc., garners the largest share or the largest number of breaches. But there is a percentage that we are seeing with respect to cybercrime initiatives and hacker activity like we've seen just recently. And of course we have a certain percentage, a fairly good percentage, that are attributable to third-party service providers that work with covered entities. So really they are all represented here. And so really when we think about protecting our environment, what I'd like you to think of is that we need to think about all of these different threats, both external, internal, and our partners that we work with out there. Let's talk about that landscape. So when you look at the threat picture that we have in healthcare today, it's actually evolved quite rapidly over the last few years. If you go back 5 years ago, you would have seen the same chart put out by Symantec in their annual report, and it would have had healthcare listed somewhere around 20th with respect to industry attention in terms of number of events that have occurred in a particular industry. In 2009, healthcare moved into the number 2 slot. In 2010 and 2011, we took over the number 1 slot. And that's really important and significant to understand in that we are in an industry now where we are seeing more incidents occur. And these are not just the incidents that I talked about before with respect to inadvertent disclosure. These are also incidents in terms of directed attacks from malware and that sort of thing that the threat centers monitor and the laboratories monitor. And it's pretty significant that we have a real threat out there to our data. And part of the reason for that is because we have a tremendous amount of personally identifiable information that's actually quite valuable. When you think about it from an awareness perspective, as I talked about before on that factoid slide, you know, that first picture up there, that's the guy that gets all the attention. He gets the headline. He gets the really cool picture. He gets to wear the sunglasses, etc. But in actuality, it's the person down there that works for us that is really trying to get their job done every day and working hard and a good person, and that really, unfortunately, inadvertently creates, right now at least, the greatest amount of risk or the greatest amount of exposure to the data that we have for our patients. And James, what are you seeing with respect to that?
Well, from the threat perspective, of course, you know, in looking at this, and I know you showed your slide before talking about where we've come in the last couple of years. It's interesting that the industry initially really focused on, for a long time, forward-facing tools like firewall protection to protect you from a hacker. And really, from a hospital's perspective, we tend to operate on that trust principle, allowing our internal folks to be able to look at any data, understanding that we trust them to look at what they're supposed to appropriately, and really can understand that that's a pretty significant opportunity for violation.
Super. So let's go to our next factoid. What percentage of healthcare organizations reported at least one known case of medical identity theft by a patient in the past 12 months? So I'll give you a second there. So was it almost 90%? Approximately 50%, more than 10, less than 5? Well, the answer is approximately 50%. That's pretty significant when you think about it. That means 1 in 2 hospitals in America reported at least one case of medical identity theft in the last 12 months. And that's when you think about that number, that's pretty significant. And that means that there were some that reported more, obviously some that did not. But the fact of the matter is that at least 50% of our hospitals out there have experienced one of these events at least once in the last 12 months. That tells you right there that there's information out there that's of value, that people are willing to steal. And if you look at, for instance, if you look at the black market and you look at the price of the average Social Security number on the black market today, it's about $1 a number. If you look at the price for a medical identity, it's about $50 an identity. So it has value, and unfortunately, when things have value, there are people willing to do things that they shouldn't to get them. So let's talk about some of the things we saw in some of the surveys that I think are important with respect to threat as well. And this particular survey is one that's run every year by HIMSS. I've had the pleasure of working with the folks on this survey in terms of some of the questions that get asked each year for the last 4 or 5 years. This one was actually commissioned by Kroll Advisory Services, which is one of the things that we really appreciate at HIMSS is the folks that sponsor these surveys. This one actually included 250 CISOs from around the country. And the respondents there you see, notice they reported 25% increase in the number of breaches experienced. So we've got 1 in 2 hospitals reporting that they've had medical identity theft, and we've got 1 in 4 basically saying that they've had an increase in the number of breaches that they've seen. Now, obviously, part of that, I assume, is actually recognizing these things and reporting them for the first times. But what's also interesting in this, and I want to make sure we stay grounded in this discussion, is that it's not just electronic data that we're concerned about. And HITECH, of course, expands it to all forms of PHI, both verbal, written, and electronic. And the misuse of paper records, as we see here, was still a big portion of the breach activity that we saw out there. So there's still a lot of paper-based issues that we have. What's interesting too is that 79% of the incidents were attributed to employees, and again, that's that percentage, that high percentage of incidents that are attributed to folks that work within our organization. So just kind of an understanding again of just where we are in this threat picture. When you look at the number of security incidents and you look at the breach numbers and what that tells us from year to year, we've certainly been increasing every year, and we've seen a greater increase in since 2009, and part of that's probably because it's now being reported. But we saw a 32% increase in the number of breaches in 2011 from 2010. And 97% of those increase in the total number of records breached. I think everybody realizes that there were about 3 or 4 breaches in 2011 that had significant numbers associated with them, such as the TRICARE breach that had 4.9 million records at one blow. 59% of the breaches involved business associates, a significant number, right, when you think of it in that regard. 60% of the increased breaches due to malicious intent, theft or hacking, somebody actually stealing a device or stealing the information, or somebody breaking in to the system in some manner. And 400 plus major breaches that we've seen, and of course the number now is well over 20 million when you look at the total number of people exposed. James, what do you have to say about that?
So likely, that problem has existed for many, many years. Certainly trending, you said before on your slide as well, talking about that we're reporting it more now, so really it's maybe coming to the forefront more often. When we do our installs with a product like Security Audit Manager, and we work through, with the hospital who's doing this for the first time and doing some of this collection, it's really interesting because most of the time they think that they're fine, they're well protected, they've got a good education program explaining to their people that don't look at stuff they're not supposed to or they'll get caught, etc. But every single time, we find that there's violations that are occurring there just because it's possible to do because of your inside security breaches.
Super. Okay. So let's have another factoid. Healthcare organizations are required to perform a risk analysis as a key HIPAA requirement and a key criterion of qualifying as a meaningful user. What percentage of hospitals proactively conduct or review a risk assessment? Now, of course, this is according to the survey. Is it almost 90%, nearly 70%, approximately 45%, or fewer than 25%? Well, the answer, according to the survey, is nearly 70% of our hospitals conduct or review risk assessments on a regular basis. That unfortunately means that 30% of our hospitals do not. And if you look at, as you're going to hear me talk about later when we get into the audit results, if you look at the audit results from the first 20 random audits, you would be led to believe that even fewer are conducting risk assessments that actually meet the requirement. So this is a big concern, and it's a very important aspect of our program, because that risk assessment not only provides us with the basis for knowing what it is we need to address from a risk or threat perspective, but it also helps us to measure over time how our controls are working. And so if we're not conducting those risk assessments or not conducting those periodic reviews, if you will, things can happen. Things can become open or at risk, and unfortunately we won't know that until it's too late. So when we look at the next slide there, it talks about new threats worsen the risks. This is something that I've been spending a lot of time on with folks lately, because I think it's important for us to understand how the landscape continues to evolve, and that's why that section is titled this way. So this whole idea of digitization of patient information, which places more and more people at risk because more and more information is now in digital form, is actually very, very accurate. But what's more accurate about this, that I think, and I've heard this from a couple of other folks, is that whole digitization process begins to have people think about patient information, if you will, as data. And when you start thinking about it as data, you begin to not think about it as information that belongs to a person, that's important from both a privacy and a safety perspective. So we really need to be careful to make sure that as we digitize more and more of the medical record to get the benefit of doing that, which is absolutely true, that we also don't forget that we're still dealing with a human being and that we don't lose that personal connection to that information. Medical devices present an enormous risk in our environments today, and the Office of National Coordinator just had a roundtable not too long ago with respect to mobile device security, where we talked about not only mobile devices but medical devices as well. And they do present quite a challenge for us because in many cases those devices are now being networked and they're being connected via wireless communication, etc. And we've seen that if those things are not protected properly, they can present a real risk to patients. One of the real risks that concerns me, of course, is some of the things that we've seen in some of the conferences, such as Black Hat or DEF CON or RSA, where people have decided that it's actually time to begin to demonstrate the vulnerabilities in these systems and demonstrate how you can hack certain medical devices and cause them to do things that they were not intended to do. Like, for instance, the individual who hacked an insulin pump during a demonstration at RSA this year with a see-through mannequin, where he actually demonstrated that he could take over the signal to that pump and cause that pump to inject a lethal dose into a pancreas in that dummy, and as if that was a responsible thing to do. I don't argue that we need to be aware of these risks. There's just a certain amount of responsibility I think we have in terms of what we demonstrate and what we show folks can be done. But certainly it brings out the point that this is not just a confidentiality issue anymore, it's also a patient safety issue, and understanding where our systems are and how they're behaving and who's able to access them is incredibly important. We've seen directed attacks from malware in the last couple of years that have been very specific to healthcare, and in fact we had at least one customer who was the victim of this. Unfortunately, because of quick reaction, we were able to stop the attack before it actually caused damage or created a breach, but it created significant effort on their part in terms of cleanup, and it demonstrated in real time that there are indeed malware out there that are attacking healthcare organizations to harvest healthcare information and send it offshore to folks who would obviously sell it on the black market. And then last but not least, we have sophisticated botnets that are out there that are beginning to be used to perpetrate fraud on a wide scale that are really indifferent to who they attack or the system that they attack. And they're really looking for folks that aren't maintaining their systems adequately and finding that chink in the armor that they can then take advantage of. James, what are you seeing in these areas?
Well, I think the digitization of patient information, I think, is an important concept too. If you look at that as well, people not only having more people and more information there, but also having more access. I mean, think about before, if you guys can remember the old medical records department, where there were just shelves and shelves and shelves of medical records that were secured by lock and key. That effectively is gone now, and the lock and key is really on the front line of those systems being an electronic medical record at this point. That going back to that care principle, that trust principle that we talked about before, allowing those caregivers to give access or have access to whatever they need. And that trust component of saying that we need you to look at what you're supposed to. So certainly them having more access to look at information from anywhere, I think, is pretty important as well.
Sure. So let's talk about HITECH for a second. New rules, and kind of reminds me of the title of the Bill Maher show on HBO, but these are a little bit different, obviously. There are many new rules, as we say here, that are emerging. I think everybody has been paying attention closely to, hopefully, the meaningful use at Stage 2 NPRM that just came out and that is in public comment now, as well as the EHR implementation standard certification criteria that's out there for public comment. And I actually did a webcast yesterday where we talked about this in detail. There are some significant changes in those rules that folks need to be aware of and need to be thinking about It's going to change the way we do our risk assessment from a meaningful use perspective, in the sense that we're going to now have to document our strategy with respect to encryption and document why we either did or did not encrypt something and what the rationale behind that was as part of our attestation, which is something new. We're going to have to think about secure messaging as it relates to the EHR and communication with the patient as one of the measurable events. There are numerous changes to the EHR certification criteria to include some changes around encryption, auditing, the integrity function. They've combined authentication and access and authorization into one requirement as opposed to keeping them as separate components. So there are some changes that we need to be conscious of. There's some things that if you haven't looked at those, you might want to look at those. There's still time to make a comment if you want to have your voice heard. I think there's going to be some changes before that final rule comes out, because I think there's some things in those two requirements that are somewhat contrary to the original intent of the HIPAA security and privacy rule. And of course, that's not what they're supposed to do. But I think the rest of the changes we're probably going to see, and it's going to cause us to have to modify again our approach in some ways to some of the things that we're doing. The other big rule that's going to be coming out before too long, because it's already gone over to the Office of Management and Budget for review, for their final review, is the Omnibus Rule. And if you recall, the Omnibus Rule contains all of the changes with respect to HITECH except accounting for disclosure. And accounting for disclosure will come out later, and it will come out separately. But when this Omnibus Rule comes out, you're going to have the changes that affect business associates, minimal necessary, patient restrictions of access, marketing and sale of protected health information, etc. So there's going to be multiple new aspects to the HIPAA security rule, if you will, that are going to come out when the Omnibus Rule is published, that we're also going to have to adjust to in our programs. And so I'll talk a little bit about that in terms of some of the insights we saw during the OCR audit process, but I encourage everybody to take a look at these NPRMs and to take a look at this Omnibus Rule in preparation for it coming out. Let's do another factoid. So, how many organizations report having the capability to proactively monitor for indicators of medical identity theft and notify security compliance staff? Now, there's a lot of folks that say they do monitor certain aspects of their environment, but when you look at the answers there, the answer for this one is unfortunately fewer than 30% actually proactively monitor their environment. So a lot of folks are auditing in a reactive mode. A lot of folks are auditing based on somebody asking a question or an event occurring, but there are very few that are actually proactively collecting information on a regular basis in real time and receiving alerts and reports and then acting on those reports in a proactive manner. And what that means, unfortunately, for a lot of us is that we're going to learn about things after the fact, which unfortunately in many cases means that it will be, the situation will be much worse by the time we are able to address it. So when we look at that whole enforcement regime, if you will, as it relates to what goes on, HIPAA privacy and security, as we all know, are enforced by the Office of Civil Rights. When you look at the workload that office has, it's fairly significant. They've had over 66,000 complaints since 2009. They've had more than 15,000 corrective actions, which is fairly significant. So that means 15,000 times there have been organizations that have been directed to perform some type of corrective action from OCR. Over 55,000 breaches were reported by the end of 2011. Many of those were minor, obviously, breaches. but more than 400 of those were major breaches that included or involved more than 500 personal records. And then, of course, they have the random compliance audit program, which they just began this past December. So there's basically 3 elements to their enforcement program, one being the complaint resolution process, the second one being the investigations of the breaches that occur, and they do run an investigation of every major breach that occurs. And last but not least, the random compliance audit program that they now have in place as well. Meaningful use attestations enforcement is the purview of CMS and the Office of the Inspector General. That's a totally different regime. It is about incentives. It's about Medicare, Medicaid reimbursement. And so it's the Office of the Inspector General that would audit an attestation of an organization. In fact, that's part of their annual plan for their audits for this year. And last, we also have state attorneys general, who some of which have been active in filing various lawsuits against organizations within their state. And last but not least, we have class action and civil lawsuits, which have really had an uptick in the last couple of years. And in particular now, whenever there is a major breach, it is not too terribly far behind it that there is a lawsuit filed by somebody with respect to that event, and which just complicates things even further for our covered entities. James, what are you seeing?
So, you know, it would be bad enough, I guess, if you had lawsuits and corrective actions, you know, weren't bad enough, but you also got to remember there's a component there for really a very public reporting of violations. So, you know, it can be really negatively affect the hospital because, you know, especially where you have tightly geographically centered hospitals where people can choose to go to hospital A or B just because they're right down the street. Having hospital A on the news the day before because they have a huge data breach on Channel 9 News probably not going to be good for your bottom line or revenue.
Yeah, you know, and that's a very good point. And, you know, it's very interesting that I think Mr. Rodriguez, who is now the head of OCR, has been fairly straightforward with respect to his expectations around compliance and the fact that he expects enforcement activity to increase. And in fact, if you look at just this year, you've had the Blue Cross Blue Shield of Tennessee incident, which went to a resolution and a fine. And just today, you had another one reported, which was a Phoenix cardiac surgery practice, physician practice out in Phoenix, Arizona, who was also found lacking with respect to their compliance and was fined. So if there's any question about whether size has anything to do with it, I think that OCR is doing their part to dispel that. So let's talk about that audit review process, or that audit process that OCR now has in place with respect to its random audits. And in this particular case, we were very fortunate, or unfortunate, whichever way you look at it. One of our customers that we've worked with for quite some time was actually selected as one of the initial 20 folks to go through this audit process. And they asked us to provide support to them throughout the audit. So from the time that they received their letter to the time that they reviewed their report and provided their responses back to KPMG and OCR, we were with them the entire way and helped them not only in the preparation phase but throughout the audit, and then finally with the report itself. So let's talk about that timeline first, because there is a very definite timeline to these audits, and I think it's something that we need to understand and appreciate, and that is that the audit process is very rigid. The process starts off with a notification letter from OCR. It's actually a 3-part letter that has a letter from OCR which designates KPMG as an agent of the government to perform the audit, and tells the organization that they have been selected under the HITECH Act for this audit purpose. The letter then from KPMG, the second part of it, actually introduces the audit process, the audit team, provides information with respect to notification or questions that they might have, that the organization might have, and then it explains the first audit requirement, which is a documentation request, which is attached, which is an attachment to the second letter, which provides a list of documentation or types of documentation that the organization needs to pull together and provide back to KPMG within 10 business days of the date of the letter. And we'll go over that list in just a minute. From there, there's a quick conference call with the folks at KPMG that are going to be running the audit for the organization, where they actually explain the audit process. They go over the timeline. They go over the logistics requirements that they have to support their team. And then they basically tell the site that they will await their documentation, which they expect within 10 days, and that they can expect the on-site portion of the audit to begin anywhere from 30 to 90 days from the date of the letter, and that they will be given minimally 5 days notice before the team arrives on site to begin their audit. When the team does arrive on site, they conduct the on-site portion, and then when the on-site portion is over, they can ask additional questions or request additional information for some period of time after the on-site presence while they're writing their report and conducting their analysis. They draft their report, and generally within 30 days they have that report to the site. The site then is given 10 days to respond to that report and provide their comments back to KPMG. KPMG then has additional time to review the comments against their report and decide if there's something in the report that they need or should or want to alter or refine. If not, they basically are required to send the report and the comments off to OCR for resolution. Let's do a little factoid again. So, what percentage of healthcare organizations still do not have incident response or breach notification procedures documented? You probably would be surprised with the number of breaches that we've had in the last couple of years that anybody would not have those things documented. But in fact, we actually have about 30% of our organizations out there, according to the survey, that have not documented their incident response or notification procedures, which I think is surprising on one hand, and very risky on the other. Obviously, the last thing you want to do when you're in the middle of a breach or the middle of an incident is to be having to try to figure out who needs to respond, how you need to respond, who's going to make the notification, who you're going to make the notification to, etc. This is really something that we should give some thought to way ahead of time and have documented. And quite frankly, it's a HIPAA requirement to have it documented, so we should have it done now anyway. So let's talk about that documentation request, that first requirement in that audit process, that OCR audit process. This is a kind of a summation of the types of documentation or types of documents requested in the attachment to that letter. All kinds of demographic information, obviously policies and procedures from a privacy and security perspective, key person information with respect to the organization, organization charts, training, privacy documentation, plans, pretty much all the types of information that one would expect an auditor to request or to collect in order to be able to conduct an audit of your program. How well you have this information organized, or how well you have this information placed within your system where you can actually access it, will actually affect how well or how quickly you can respond to this requirement. I will tell you that with the folks that we worked with, this was not a trivial task. And I've heard from a lot of other organizations that this is something that they're very concerned with. And quite frankly, I think that's very, very appropriate with respect to this. So let's talk about the site visit. So once they have the documentation, they're going to review it. Then they're going to actually decide when they're going to come on site, and they're going to notify us that they're coming. The protocol says that they can be on site from anywhere from 3 to 10 business days, depending on the size of the organization and how much time they feel they need to conduct the on-site portion of the audit. The protocol says that there can be anywhere from 3 to 5 auditors, and it talks about the various expertise that you will likely see in your audit team that shows up at your site, and reminds us that, of course, that this on-site portion of the event can actually happen on short notice. James, I think you had something you wanted to say there with respect to that.
Yeah, absolutely. So in that slide before, actually, we were talking about being 30 to 60 days or 30 to 90 days notice. Understand that, at that point, it's a little late at that point to put together a program for this. So Mac's comments there about being prepared for this is absolutely critical. And really being able to, if you look at that pretty intensive 3 to 10 business day activity that's occurring, you need something that's going to allow you to produce those type of reports and produce that type of information without having to dig for that. And that's where a tool that aggregates that information really comes in and is very important.
Super. So let's have another factoid real quick. Role-based access controls are used what percentage of the time in healthcare to manage access to PHI? I'll give you a second there. So I don't think anybody believes it's 100% of the time. And it's certainly not less than or greater than 25% or less than 50%. So the answer is really that 65%. And the reason that that's significant is because having well-documented roles with respect to our users and what a person should have access to and what a person should be able to do in the system is really the underpinning of everything else we need to do from a security monitoring perspective. And I can't overemphasize enough that if we don't have good roles defined for our users and implemented in our systems, it becomes very difficult for auditors or investigators or compliance folks or anyone for that matter to actually understand exactly what someone did and whether or not what somebody did was appropriate or not, or relevant or not. I can tell you also that in the OCR audit process that it was one of the areas that they spent a considerable amount of time on and asked a lot of questions with respect to how they were managing access management and how users were indeed provisioned in the system and what level of analysis was applied to their roles, minimal necessary, etc. So it is a very important component of our program. During the actual on-site portion, they'll actually perform physical tours and interviews of staff. So it's very important that we prepare folks for this experience. In fact, when they came on site at the hospital that we observed, they interviewed a significant number of the executive level folks at this hospital. They spent an enormous amount of time with the privacy officer, the security officer, and the compliance officer, which you would expect. But they also spent time with each one of the department head folks, such as HR, legal, etc., other people who had different roles in managing the program, if you will. And then they spent time on the floors with the people out on the floor in terms of the folks who were the staff and the workforce members who were actually getting things done. So it's very important that we prepare all of those folks for that process. In fact, when we were working with the hospital, we were working with one of the things we did between the time that they got their notice and the time that the on-site portion of the audit began. We actually worked with them and worked with their staff and provided several sessions to their staff to help them get ready for this experience. and to know what to expect, and to also rethink everything with respect to privacy and security that they were doing, and refresh all that information for them in their minds so that they would be better prepared to answer questions. The interviews with non-leadership folks actually do occur on the floor. They also examine the physical layout of the place with respect to how systems are managed, and they looked very deeply into operating practices and processes. Audit reports. The audit report itself was fairly detailed in the sense that it actually covers the information about the organization, talks about the methodology that they follow, and they do follow their methodology very closely. It provided their findings, it talked about best practices, gave some overall conclusions, and the report itself does give the organization an opportunity to respond, which I talked about before. Let's do another factoid real quick. So, accounting for disclosure, one of our favorite subjects for everybody, was said to be one of the least likely uses of audit logging. But what percentage of hospitals report using audit log data for this purpose? Okay. So again, I'll give you a second there. So again, it's not that almost 90, which we'd like it to be, but in this case, it's even not only the nearly 70, it's approximately 45% overall. And so what this means essentially is that, and we're really talking about, again, from an automated perspective, you know, how many organizations are actually actively collecting this log information from their systems, from their applications, and have some process around proactively looking at this information and determining whether or not there's something there that is of interest or that they need to be aware of and take action on. Audit findings. Again, the report itself, when you received the report, it was laid out exactly as the contract required them to provide it. There was a condition in the report for each specification, if you will, that talked about what they observed from a non-compliance perspective and the evidence that supported that. There was a criterion given, which was the citation of the provision or provisions that were potentially violated. There were reasons given for the non-compliance that were observed or gathered during the audit process. They also talked about the risk that could result from that particular situation. And then they gave a recommendation with respect to what the organization needed to do. And if there had been corrective action taken, they actually identified that. So in fact, in one particular instance with the hospital that we were at, there was an issue that came up, and there was an example of non-compliance where the organization actually took action immediately and corrected it. It didn't change the finding. They don't change the finding. They still found the organization deficient with respect to that requirement, but they did note that the organization fixed it during the actual audit process, so that OCR would see that even though it was found deficient at the beginning of the audit, it was actually corrected before the audit was complete. So let's talk about some of the things that we learned in this process. One of the things we learned with respect to risk analysis is that they took a very hard look at the thoroughness, the methodology, and the currency of the risk assessment or the risk analysis that organizations were performing. They looked specifically at whether or not both technical and non-technical controls were being tested as part of that risk analysis perspective or process. They looked at the actual scope of the risk analysis in terms of whether it was an enterprise level risk analysis or whether it was more of an isolated risk analysis. They looked at the approach to the risk analysis in terms of identifying the threat, identifying the vulnerabilities, doing the analysis with respect to likelihood and impact, identifying countermeasures that might be there to mitigate some of that risk, and then coming up with recommendations for what needed to be done. They also looked to see if whether that risk analysis was part of an ongoing risk management program in terms of whether it was repeated or whether or not it was just a one-time thing and not really followed up on, or whether or not there was a remediation plan in place with respect to that risk assessment. And one of the things I'd like to kind of remind everybody about is that meaningful use and other aspects of HITECH actually address risk assessment, and it is the same risk assessment requirement that we have in the basic HIPAA security rule, and that's what they're looking for when they're auditing. So let's do another factoid real quick. In all, more than 55,000 breaches have been reported to OCR since 2009, 400 plus involving more than 500 records, The majority of those breaches involved laptops, removable media, paper and images, or servers. Give you 2 seconds on that one. Well, a lot of folks would say it was probably laptops and removable media, but in fact it was not. The majority of breaches that we've had involve paper still. They're generally much smaller. The larger breaches, of course, are the breaches that we see that are in electronic form, but we still, the overwhelming majority of breaches that we have, believe it or not, are still paper-based. So it's important to remember that and to address all forms of PHI. Activity monitoring. What did the auditors want to know about that? Well, first of all, they wanted to know that audit logging and monitoring was being performed. They wanted to know that logging was enabled on all systems that had PHI. They wanted to know that somebody had developed or thought through an audit plan, and they asked for documentation to support that. They wanted to see that auditing was being performed and that there was evidence that it was indeed being performed. And again, I'd like to remind everybody that there are several omnibus rule requirements in accounting for disclosure that are going to increase the need for automated auditing. Things like paying closer attention to minimal necessary, paying closer attention to requests for restrictions to access by patients, etc., that are just going to make this whole auditing requirement even more important for us. James, I think you had something you wanted to say there as well.
Yeah, so one would think on that logging enabled that most systems out there are going to have logging enabled already, but we find on our installs that not only is logging not enabled, or maybe enabled to a specific event, but maybe not through all events. And also there's the issue that even if that logging is enabled, we've got a lot of systems that we go to where they'll have that audit log that purges after a specific date and time, which doesn't help you a tremendous amount when you're trying to prove that you're monitoring that.
Super. So let's talk about access management. What did auditors want to know there? And I alluded to this a little bit earlier, so I won't cover that again. But they wanted to know that we had well-defined processes there. Again, that role-based access and defining what roles were for individuals in the system. Application of minimal necessary, they asked about that several times. The process around provisioning and who had control of that, or who actually did that. The whole process around authorization and who approved accesses for folks. Changes and terminations in terms of whether or not the practices that we were following met the policies that we had documented. The whole idea is about this is, do we have a good process in place or good rules in place and enough oversight of that process to truly know what our users are doing, whether what they're doing meets what their role or what their position requires them to be able to do. And again, this whole aspect of more specificity in terms of being able to be more granular in controlling user access and/or access to patient information in general with respect to restrictions and minimal necessary, et cetera, is just going to put even more strain on those systems and more requirement for oversight. So let's do another factoid real quick. More than 20 million patient records have been put at risk due to breach. 67% of the time, this was the result of what? So was it hacking? Was it theft or loss, mishandling of information, or malware? Well, I can tell you that it's as a result of all of these things, but the majority of the time, for the majority of the records, it's been theft or loss. Actual theft or loss of a physical device. And in fact, this is where those lost laptops, lost thumb drives, etc., backup tapes, you name it, become so dangerous for us, in the sense that typically when we lose one of those assets, we're talking numbers in the thousands with respect to records, as opposed to numbers in the tens or hundreds as it relates to smaller paper-based breaches. So theft and loss is still leading the pack with respect to where most of our data is being put at risk. So let's talk about third-party relationships, another area that the auditors spend a tremendous amount of time on during the OCR audit. You know, one of the things that they wanted to know was that covered entities were not only putting business associate agreements in place, but that they had a process for measuring the due diligence or doing due diligence on third parties before they contracted with them, monitoring that third-party relationship while they were working together, and then good procedures for the termination of that contract that covered the retrieval or the destruction of any data that third party might have in their possession. I can tell you that this was an area that was extremely challenging for the hospital that we were working with. They did have business associate agreements in place with all of their vendors, but there wasn't a lot of specificity or a lot of due diligence done with respect to checking their vendors in terms of their security program. So what kinds of things that they were asking about? They were asking if they had received any kind of a third-party assessment from the vendor before they contracted with them that spoke to their security. They asked if they'd seen any of the policies and procedures from that vendor. For those vendors that were hosting any systems for them or hosting any data for them, they asked if they had procedures for disaster recovery and backup, and whether or not those backups had been tested, and whether or not they had any documentation to prove that those backups had been tested successfully. So there was a considerable amount of emphasis placed on these third-party relationships, which is something that we actually address quite a lot with the hospitals that we work with, in terms of being able to actually vet those third parties and have a much better feel for how well they are capable of protecting that data that they might be sharing with them. And James, I think you wanted to say something here as well.
Yeah, we're certainly seeing this as a pretty growing part of the business of people trying to protect their BAAs, and really we have a BAA module that we're putting in place right now that allows you to track that information, as well as our medical records release manager to allow you to kind of keep all of that third-party information together, as we see that as probably if not the second most question that we're asked about protecting that information on a daily basis.
Great. So the next area that they were very interested in was knowing actually where the protected health information was. And you know, one of the requirements for just HIPAA privacy and security in general is our ability to basically map where the PHI is in our environment, but also for breach notification, meaningful use, and a lot of other rules. It's becoming more and more important that we not only have a notional idea of where the data is, but we actually have a real knowledge of where that data is. And this is where, again, this is just one of those requirements that is becoming complex enough that we can't do it manually anymore. We need to use proper technologies that allow us to be able to find where the data is accurately within our environment, and to be able to put controls around that data itself that help support the other controls that we have in our environment, and take some of the stress off of some of our endpoint solutions, if you will. So things like data loss prevention technologies that enable us to actually go out there and accurately map and identify and index where information is, and then be able to put rules around that data that forces it to live in locations where we want it to live, or forces it not to be put in places where we don't want it to be put, for instance on desktops or certain devices, become very important as part of our overall strategy for enforcing our rules around data protection. Again, they asked about encryption as it related to this. They wanted to know a lot about the encryption strategy for the organization. You know, did they know where their data was? Did they know where they needed to apply encryption? Had they actually thought through that process? Had they either applied encryption or documented the rationale for why they weren't going to apply encryption, and what other processes or controls they were going to use in lieu of encryption to actually protect this information. So again, it was, and of course the question came up, have you considered using technology to support this process? And that was one of the things they asked in multiple areas, to include audit, logging, etc., with respect to the organization's responses. Another factoid: business associates represents an important component of covered entities operations. While vendors were a part of less than 30% of the major breaches, although that number's gone up, as you heard earlier, they account for what percentage of the records exposed? So this is kind of one of those interesting relationships, if you will, where while vendors or third-party service providers only account for a percentage of the breaches that we have, the total number of breaches that we have in healthcare, the number of individual records that those breaches account for is close to 75%. So that's significant. So and what that says is that we have a tremendous amount of information that we share with third parties, and that typically when there is a breach with respect to one of those relationships, it tends to be around an electronic transfer or electronic device or storage media, etc. And typically we're talking, again, unfortunately, you know, in the thousands, as opposed to in the single digits with respect to numbers of records. And so even though they account for not the whole in terms of numbers of breaches, they account for a significant number of records exposed in those breaches. Application of encryption. I talked about that briefly a moment ago. Encryption is addressed in multiple HIPAA and HITECH rules to include meaningful use, the EHR certification criteria, the breach notification rule. And in fact, during the audit process, they were focused obviously on HIPAA security, HIPAA privacy, and the breach notification rules, so they wanted to know what the organization had in place with respect to that whole incident handling response capability. But more importantly, they really wanted to know what the organization had in place with respect to an encryption strategy. And again, like I said, you know, what had they identified where the information was, what information needed to be encrypted, and how they were handling that. Last area, disaster recovery planning, which was another area they covered quite heavily, and they covered this area not only with respect to the covered entity, but also with respect to third-party service providers in terms of what type of disaster recovery planning had their third parties or their vendors done that they were sharing information with. And they wanted to know, did they have all the components of a disaster recovery plan? Had they done their criticality analysis, and did they have that documented? Did they have a basic response procedure? Did they have recovery procedures for various systems? Did they have downtime procedures, et cetera? And did they have a process for managing all of this? And James, I think you had something you wanted to say there as well.
Yeah, absolutely. And thinking about what you talked about before with the you know, data being electronic, and thinking about there's hundreds of systems there, we see that as well, and being able to bring all that data in from hundreds of different systems into one you know, kind of centralized location so that you can search across it.
Super. Okay. So last factoid. When surveyed, patients reported a high degree of confidence in their primary care physician regarding privacy. When asked about health organizations and government, they responded with high confidence, moderate confidence, or low confidence, or very low confidence. Well, the bad news is they responded with very low confidence. In fact, less than 20% said they trusted large organizations, health health insurers, government organizations, etc. And it really came down to a difference between how they trust organizations versus individuals. I think that's one of the things that we need to work on very heavily in this community and in this industry, and that we would like, I think what we would like to see is that people have as much confidence in their health organization that they're going into or working with or visiting as they do in their primary care physician. So with that, I'd like to turn it over for questions.
Yes, and I think we're actually out of time, but we do have a couple of questions that have come through chat, and we will send a copy of all the question and answers to folks attending today for those of you that do need to drop off the call. The first question is the documentation list for OCR audits process same for physician office clinics as well?
So the protocol is the same in the sense of what they will address from a privacy, security, and breach notification perspective. What is different, obviously, is what they are looking at, because they recognize that there is obviously a difference between a physician practice and a hospital or a clearinghouse or a health insurer. So there are some differences, there's some nuances in maybe approach, but the basic protocol with respect to what's expected under the rules is the same.
Okay, the next question is, who generally receives the notification letter from OCR, the organization's legal counsel?
So the letter is actually addressed to the CEO or the administrator of the hospital. So it's an official letter to the leadership of the hospital itself.